dilate, get bigger. You need to have bigger airways.
To nap?
You gotta breathe.
What if you need to run from that spider? You don't think your
Oh,
airways
that's
can
true.
dilate
That's
in?
running. I'm not afraid of spiders, so I'm not gonna run from
Okay,
it.
well, whatever you are scared of, when you need to run or fight for your life, your airways need to open up.
Yes.
So, what system are these drugs mimicking?
Your sympathetic nerves.
So these drugs are also called
The
sympatho.
sympatholytics.
It's mimicking that system, so it's a sympathomimetic.
Okay.
And what's an example?
I mean, albuterol.
Yep, good. Yep. Albuterol. So of course, norepinephrine is that receptor that's a part of your sympathetic nervous system. So a drug that stimulates any receptor that responds to norepinephrine would also be an adrenergic or a sympathomimetic, like albuterol. Okay, good. All right, Andrika. What are three potential adverse effects of using adrenergic bronchodilators?
So an adverse effect would be something that happened when using them.
Like a side effect, something that you don't want to happen. That stuff.
Um, bronchospasms.
Well, adrenergics they work to cause bronchodilation to open up your airways, so they're not going to cause them to spasm. So not that one. What was the second one you said?
Absent a fast heart rate,
Yep. AKA.
tachycardia,
Yep. So tachycardia is definitely one. What else?
maybe heart palpitations.
Yeah. Okay. And usually, it's what they're really feeling is that tachycardia. It shouldn't make you go into an arrhythmia.
Okay.
What else? You ever drink too much coffee? Too many Red Bulls?
Yeah, it make you nervous.
Yeah. So nervousness. What else? What your hands feel like?
Tingling, sweaty. Shaking. Shaking.
Yep. So jitteriness. How do you feel before an exam?
Yeah, I'm nervous.
That would be your fight or flight system.
Yeah. Could you become hyperglycemic as well?
Well, that's because you don't eat.
Okay.
Yeah.
Okay.
So, but normally, no. They can become hypo something. What electrolyte does albuterol affect?
Hypokalemic,
Which is
calcium,
no. Don't let that K fool you.
potassium,
Potassium. What's normal potassium?
bananas, would it be 3 to 5?
3.5 to 5. Yep, good. Well, you can also have a worsening DQ mismatch. Because now you're opening up those airways, you're causing better ventilation, but it still may not match the perfusion. Your patient can get dizzy, they can have anorexia. So not the hypoglycemia, but like you said, you don't want to, which is why you're hypoglycemic. So they could cause you not to want to eat. Like you said, nervousness, jitteriness, anxiety, things like that. Nauseousness, eating. Yep. Good. All right, AJ. What is the other name for ipratropium bromide?
Um, that is it Formage? Formoterol?
No,
No?
no. Ipratropium bromide. I appreciate you having a resource,
Um,
but I don't think you're looking at the right thing.
that is Atrovent.
Good. Atropine. What kind of drug is it?
That is going to be a anticholinergic,
It sure is, AKA.
parasympathomimetic.
Is it mimicking the parasympathetic nervous system?
It is parasympatholytic.
Yes, it is blocking the parasympathetic nervous system. And what is the normal dose if you were going to give Atrovent via an inhaler?
It'd be two puffs 4 times a day.
Yep, 2 puffs 4 times a day. What is the normal dosage as far as milligrams if you were given it via small volume neb?
It would be 0.2 milligrams per milliliter 4 times a day.
Yep, so usually we give 2 milliliters and it's actually 0.5 milligrams. Good. So isn't it timely, by the way, that these pharmacology questions are coming up? Because please remember that Wednesday is your pharmacology lab. So please, please, please make sure that you go back and study your pharm. It does not go away. Y'all know how I feel about pharm. Please don't go into your patient's rooms and you know nothing about drugs and your plan is to give them one of those drugs. That's not cool, okay? So make sure that you go and study your drugs. I've talked to you guys about being better prepared for lab, bringing, well, 1, having some stuff in here, and 2, for the stuff that didn't quite fit in here, making sure that you have a resource to look it up, okay? So that's my speech for lab. We're gonna have a much better lab on Wednesday than we have with some past labs, but it'll be all farm. Yay, your favorite. So, and you will have farm questions on your midterm as well, okay?
Ms. Gardner,
Yes.
last in 210, did you send us pharmacology videos?
I can't.
Because I made sure I starred all the videos so I could just go back and get them, but mine goes straight from aerosol humidity to hyperventilation.
I might not have because I know that I gave you guys handouts.
Okay.
Or because really the only thing would have been like the administration. So I don't think I did, but I'll send you guys some administration on how to properly give an MDI, SMI.
Okay, I was mostly looking for it so we could do our clinical simulations for it, but I just didn't know if I missed one or not, but when I went through it, skipped pharmacology in the video.
Yeah. Now that I think about it, I don't think so.
Okay.
Yeah, I think you just went off from the handouts for your templates. Yeah. But I'll send you some for the clinical simulations. Okay. Whoa. Floridil is the brand name for what drug?
Floridil is I did not want to do oh my gosh, I can't even oh, it's on the tip of my tongue.
Is that a dog or a smoke detector or
That's,
is it?
it's my dog, I'm sorry.
That one is
You are now muted.
Floridil, you said? Furosemide?
Floridil.
No, Floridil. It's formoterol.
It is from Motorol. What kind of drug is that? And Mallory, you went away.
That's oh my gosh. Adrenergic.
Okay, is it a long acting, short acting?
Oh man, hold on.
I don't remember, but I'm looking. Oh, long acting, beta 2 agonist.
Mm-hmm. So when would it be appropriate to give formoterol?
For maintenance,
Yep. So how often would your patient take it?
one puff twice a day, or a small volume nebulizer. Well, twice a day, every 12 hours.
Mm-hmm. So it wouldn't be given, 4 times a day. Because if it's a LABA, right, long-acting beta-2 agonist or long-acting bronchodilator, long-acting adrenergic, it's usually going to last for at least 24 hours. Okay. So think about it. Not only do we need to know our drugs, brand engineers, we need to know what they do. And also, by knowing what they do, we know the interval that it's appropriate to give it in. Because if a doctor order this 4 times a day or Q4 around the clock, you as a clinician should know that that's not really how it's prescribed. And at the very least, clarify or question the order. The doctor may say that that's what they want, and that's when you document, right? Mm-hmm. But you should at least recognize that that's not appropriate. Okay? Mallory, where are you? Okay. So,
I'm here.
There you are.
My daughter's having a conniption fit right now.
Oh, okay. Well, tell her you're watching. So she's going to do that later today. So, all right. So, short-acting adrenergic bronchodilators are considered what type of agent according to the National Asthma Education and Prevention Program?
Say that one more time.
Mm-hmm. Short-acting adrenergic bronchodilators are what type of drugs are called what according to the National Asthma Education and Prevention Program?
I have no idea.
Think about it. Think about what I just said. If it's a short-acting adrenergic bronchodilator, what else can it be called according to an asthma organization? Don't get into the deep so easily.
What is that? What is that? What is that?
A short-acting adrenergic bronchodilator. Is it familiar?
Say that again.
A short-acting adrenergic bronchodilator. Would it be for maintenance?
Yes. No. Short acting. Stop. Easy. Short acting. Yeah, it would be for maintenance. Right?
So for maintenance, you just want to get that drug every 4 hours. You never want to get that for a short amount of time.
So maintenance wouldn't be short acting.
Maintenance would be long acting.
But okay, that makes sense.
Yeah. So if this is short acting, it's not maintenance. So when would the patient use it?
For rescue?
Exactly. So they call them rescue drugs, rescue medicines. Because they're going to have them when they're having symptoms to rescue them. That's the way I think about it from that situation. Whereas the maintenance drug usually is a long-acting drug that kick in right away, but it's to keep it control. So we also call those drugs controller drugs, the long-acting controller drugs. Good. Yep, break that question down.
Sorry, my daughter was like,
making your brain go around.
yeah.
All right, good job. All right, Nicole. So, what are the 3 brand names for albuterol?
The 3 brand names for albuterol. Ventolin. You have Ventolin, you have, well, Aconab's common one.
Okay. Yeah, really trying to get what you're
But, yeah, and Pro Ear, my daughter used that.
Okay. What's the other common one here in the States?
Oh,
In
Levobutrin,
our region, I should say.
the common one, albuterol.
Well,
Levobutrin.
well, yeah, but I'm asking for the brand name for albuterol. So there's
The one in the States is, the one in the States is salbuterol.
the one
Is,
outside.
sorry, outside the state it's salbuterol, so inside the state it's albuterol sulfate.
Right. Okay, that's the generic for it. I'm asking you for the 3 brand names for albuterol. So you can't tell me that albuterol is the brand name for albuterol because it's not. That's the generic. So you remember albuterol comes in 3 inhalers. Comes in the red one, which is
Pro Ear.
Pro Air. Comes in a yellow one, which is
The yellow one is that the Ventolin?
no,
The Acunet?
no. I think that's one is what's that?
It's something Lin, Pro Ventolin? The yellow
Proventil.
one? Yeah.
Proventil. Yep.
Okay, I was mixing them up, sorry.
It's okay. And then your grayish, bluish one is your Vincent.
Yeah.
Yeah. Good.
I want to know it's some Lin. I try to remember them.
The only one that's a Lin is your Ventolin.
Yeah,
That's it.
and okay.
All right. So Taylor, acetylcysteine should not be used in patients with what conditions?
With asthma,
What else?
CF patients,
Yeah. And why don't we want to use that drug? Why don't we want to give that drug to those patients?
because it can cause bronchospasms.
Yep, because the main side effect of acetylcysteine is bronchospasms. What's the brand name for it?
Mucomist,
Good. And what 2 concentrations does it come in?
you talking about like the percentage, the 10 or 20%?
Yep, 10 or 20%. Good. And a lot of doctors will say to give 2 mLs or 3 mLs, but actually studies have shown that it's not effective unless you give like 5 mLs, which is a crazy amount. What does it smell like?
Rotten eggs.
Yep, good. All right, and Alfie. Oh, okay. What is the usual neurotransmitter in the sympathetic system?
Is the anticholinergic?
The neurotransmitter, not the drug. So the neurotransmitter in the sympathetic nervous system that the sympathetic nervous system uses.
Epinephrine and neuroepinephrine.
Yep, good. Epinephrine and norepinephrine are the 2 neurotransmitters used in the sympathetic nervous system. Woo, we made it past round 1. Let's do it again. Another. What term is used to describe edema in the hilar regions of both lungs, with less edema in the peripheral areas of the lungs on a chest film?
hold on. I gotta,
Okay. Use your resources. I can't be mad at that.
I'm, okay, so can you repeat the question one more time? I know you said edema in the, go ahead, repeat it.
Edema in the hilar regions of both lungs, less edema in the peripheral areas of the lungs.
Okay. Are you, is that that bat wing sign?
Mm-hmm. And it's an indication of,
Pulmonary edema?
mm-hmm. So you have those fluffy infiltrates closer to the hilum, which is, put my hands down, which is closer to, which is, what is the hilum of the lung?
That is, it's, I can't think. I can't think. It's the connection point between the yeah, it's the connection point.
What's connecting?
The why can't I think? I can't use any words. You know, your carina splits, comes down, you know, attaches to lungs.
Okay. So the point of entry
The other side.
so the point of entry for the main bronchi, where those major vessels enter the lungs.
Yeah.
Yeah. So that's going to be closer to the top middle part, or right, the middle part of the lung.
Right.
Oh, I'm sorry, not the middle part. Closer to the top part of the lungs, but towards the midline of the patient's body is where you're going to see the majority of those fluffy infiltrates. As you get out towards the periphery, out towards the lateral sides, lower towards the bases of the lungs, you're not going to see as many of those fluffy infiltrates. So if you outlined it, you would see what looks like a bat's wings if they had their wings arched up like that. So on a chest X-ray, we would call that the bat wing appearance. And of course, that's your telltale sign that the patient has pulmonary edema. If they have that, what's probably wrong with them?
Congestive heart failure.
Mm-hmm. Which is which side of the heart failure?
The left side.
Good. What should you give them?
Lasix or yeah, you can give some kind of diuretic.
Mm-hmm. Some kind of diuretic. That's our go-to usually. Lasix, aka.
I have no idea.
Phone a friend. You got 7.
Anybody, Flo, you always know this answer.
Is that fluorosamide?
Furosemide. Mm-hmm. Yeah. Yes, yeah. All right, Andrika. What X-ray view is best used to identify excess pleural fluid?
Stop.
The posterior?
Mhm.
Let me use my book.
Okay.
I think I know it, but I don't know her name. Is it the one where you laying down? Is it a lateral?
Lateral.
Oblique?
No.
I don't know this. I can picture it in my head from seeing it, but I don't know the second part of it. Lateral.
What does your resource say?
Lateral decubitus.
Lateral decubitus. Yep. So that's your lateral decubitus x-rays. What you would, if you suspect that the patient has excess pleural fluid, aka
Oh, I'm sorry. What you say?
what's another term to describe excess, a patient having excess pleural fluid?
A pleural effusion.
Yep, pleural effusion. Good. AJ, what is indicated by rounding of the costophrenic angles?
Is it the honeycomb? Or, that's fluid in the pleural space, right? For the diaphragm?
You are now unmuted.
Sorry, isn't that when you have a lateral view of the diaphragm?
No, you can see the costophrenic angle even on an upright X-ray, PA or AP. But if they're rounded, if they're no longer sharp, what does that indicate? I mean, you can see this on a lateral film too, but you can see it on a PA or AP chest X-ray as well.
And you're asking me what it means when it has that?
Yep.
That's with the diaphragm, right? Are we talking about the diaphragm here?
So the costophrenic angle is made up of where your lungs, like you see that angle as a result of your lungs and your diaphragm kind of meeting on a chest X-ray.
Okay. Was that the answer, or were you?
No, you were asking a question, so I was just answering your question.
So you were asking me about the lateral projection of.
What does it mean if your costophrenic angles are rounded on a chest X-ray? What does that indicate to you? What condition does the patient have?
they have fluid in their lungs.
Okay, so what condition would that be called? What would that be called?
It could be whatever fluid it's filled with, like
So it-
chylothorax, hemothorax.
So what's the term for if a patient has fluid in their lungs?
That would be a pleural effusion.
So you're right, it is an indication of a pleural effusion, but with the pleural effusion, is that fluid in their lung?
It's in the space.
It's in the pleural space, yeah. So that's why that angle becomes
Round.
pointed or rounded. You remember we talked about that everybody recalling? Okay. So that's an indication of excess pleural fluid or pleural effusion. And of course, how we then go forth in labeling that, it's dependent on what fluid is in there. What are your options?
Chylothorax, hemothorax, empyema.
Mm-hmm. When would it be called an empyema? What's in there? What's an empyema?
If there was pus.
Mm-hmm. All right, good. Okay, Flo, what is indicated by an air fluid level in the pleural space? So if you have air and fluid in the pleural space, what's it called?
I'm over here talking and I was muted, sorry. Pneumothorax,
You have air and fluid in the pleural space.
air and fluid. And plural. You have pleural effusion and you have pneumothorax.
So if it's both, what's the term? If it's both air and fluid.
I'm reading. Hold on one second. I was reading. Tension pneumothorax.
Mm-hmm.
I don't know what that's called. Um.
Phone a friend.
Okay, looking out.
Is it a hydropneumothorax?
It is a hydropneumothorax. Yep, good. Very good. Okay, Mallory, what term is used to describe the shadows seen on a chest film when the alveoli is filled with pus or fluid or blood?
No.
Can you say that one more time?
What is the term used to describe the shadows seen on a chest film when the alveoli is filled with blood or pus or fluid? Okay, let's open it to the floor.
Are you asking like what it's called?
The term used to describe those shadows.
So would that be like infiltrates or opacities?
Yep, so it's called infiltrates. That's those fluffy looking things that any white basically on a chest x-ray. What causes white on a chest x-ray? Not air. That could be pus, that could be blood, that could be fluid, that could be that the alveoli is closed, but it ain't no air. So it's gonna be those white patchy looking things which are called infiltrates. Good. All right, Nick Hill. Let's pick you out a good one. What is the radiographic view that's going to give you the best quality film?
Would that be a CT scan?
Radiographic.
Oh, X-rays.
What radiographic? So yeah, we're doing an X-ray for the radiographic part. But what position do you want your patient in to get the best quality film? Remember your views and your positions.
Oh, anterior? No, like, you want them to be, is it lateral anterior view?
And that's how you would do that. But so remember, with the chest x-ray, you're gonna have the film in one place. You're gonna have the source in another place. Right? Yes.
You say you're gonna have what in place?
The film
Uh-huh,
in one place, either behind or in front of the patient.
uh-huh.
Then you're gonna have the camera, the light source, either in front or behind the patient. So that's what your views are. So is it better to have the light source in front of the patient and the film behind them? Or is it better to have the light source behind the patient and the film in front of them?
It's better to have the light source behind the patient and the film in front.
Okay, so what view is that?
It wouldn't be an anterior or,
Is it shooting from front to back?
it's shooting from back to front. So it's posterior, anterior view.
Yeah, there we go. Or the posterior.
Oh my gosh.
Posterior anterior view. So why is that a better view than the AP view?
Because it shows all of the patient's lungs and it shows everything.
You still,
Huh?
you still can see the lungs and all the structures on an AP. Otherwise, they wouldn't do them, would they?
No. It just better detects the, I just put it, lack of better words.
This is a fun exercise. Huh? I said this is a fun exercise in words, huh?
Yes.
Yeah, make room for those words.
I'm visualizing, but I can't put it in words, right?
From here to here. From your brain and out your mouth. That's why we're practicing though.
It's a better view because it shows, I would say, it, I don't want to use penetrate all the lungs, but I don't know.
Okay, so why is it better than an AP?
You sounded drowned, Mr. I'm struggling to hear you. My computer volume is all the way up.
I think there's background noise from somebody's computer. I muted you and I don't hear it anymore. But why is a PA view better than an AP view?
Is this just for Nicole still, or is it for anybody?
Anybody?
Because you don't get as much view of the heart as you would for AP view.
Usually the heart is actually more true to size.
So you can see it with both views, because obviously if you couldn't see it, they wouldn't count the AP view as a legit way to do an X-ray, right? But the size of the heart becomes distorted on your AP view. Looks much bigger. You start to see shadows on the AP view. You can still see everything. It's just that you have a better quality film. You have more true to size of your structures with the PA view. When do they do an AP view?
When it's done in the room, it's like brought to you for the AP view. So it's when, like, if they can't get the patient from the room, X-ray.
Very sick patients.
So it's portable. So they would do that usually on your ICU patients who can't be transported, or you don't want to risk transporting them. So you'll take a not so great quality chest X-ray in lieu of moving that patient down to X-ray and making them stand to get that PAV. Very good. Where are we? Taylor, what lung problem is a VQ scan used to detect?
Would that be with the alveoli?
VQ scan tests for one thing. What you're looking for if you send the patient for a VQ scan.
Be perfusion, right?
Yeah, that's part of it.
And ventilation.
Uh-huh.
So you said what disease?
What condition? Yep, what problem? If their VQ scan is positive, they have this.
Just gonna guess pneumonia. No.
Friends? Somebody?
Pulmonary embolism.
Pulmonary embolism. So VQ scan is only for one thing, pulmonary embolism. So anytime you have a question and they start asking, or if the patient has signs of pulmonary embolism, what should you get? VQ scan. If it shows that they're VQ scan, if they're going for a VQ scan, they're suspecting a pulmonary embolism. If the VQ scan results are, not good, then that indicates that they have a pulmonary embolism. Okay, so you only do a VQ scan if you suspect a pulmonary embolism. Why would you suspect a pulmonary embolism? And say, let's give this person a VQ scan.
The patient has an impending sense of doom.
Yep, good. So what does that mean? What might they say to you?
They feel like something bad's gonna happen.
Yeah, they're like, something's not right. I don't feel good. Because usually pulmonary embolisms, especially ones that are significant in size, those symptoms happen quickly. It's a rapid onset of symptoms. They, don't start to have symptoms 6 months ago when they were fine, and then all of a sudden they collapse today. Okay, so what else would make you suspect that the patient has a pulmonary embolism as opposed to just something else? Where's the clot if they have a pulmonary embolism?
And the artery.
Yeah, so it's probably in the pulmonary artery. It's not in the lung, right? It's in the vessel. So some people get that confused and they think, oh, it's a clot in the airway. No, it's not in the airway. It's in the vasculature. It's in the veins or arteries that feed your lungs. So if those veins or arteries aren't feeding your lungs, what is your patient going to look like? What are going to be the signs and symptoms? What are the indications?
Would they be cyanotic?
They might be.
Hypoxemic?
They might be. What if you gave them oxygen? That fix it?
No.
Is it a perfusion problem or a ventilation problem?
Wouldn't it be a perfusion problem?
Because there's a big old clot stopping blood flow. So if you don't have blood flow, then you can give the patient all the oxygen you want. There's nothing to pick up that oxygen to deliver it to the rest of the body, right? Does that make sense? So it's not a respiratory problem, right? This is a circulatory problem. So that's why on your VQ scan, you're going to see adequate ventilation. You're not going to see adequate perfusion. You have to have ventilation to match perfusion or perfusion to match ventilation in order for your patient to have oxygenated blood to go to all the places that you need it, okay? So that's why you could even, during a code with these patients, you're bagging them, you're doing compressions, but a lot of times you lose them because you can give them all the oxygen they want. If there's no blood reaching anywhere, the blood's going to leave the heart, go to the lungs for oxygenation. You got a big old clot there, it's never going to make it back to the other side of the heart. You can give them all the oxygen you want, they're still going to be cyanotic. They're still aren't going to come up. Okay. So, and a lot of places don't use VQ scans anymore. Anybody know what they use in place of VQ scans now?
I guess would say an ultrasound.
They can. And what is it called when they ultrasound your heart?
An echocardiogram.
Echocardiogram. They can do that. Yeah. Sometimes a CT. Angiography. That's good. All right. What's the major limitation of doing an MRI of the chest on a patient?
You are now unmuted.
Never use any
This one's
object
for
that
Abby. All right, Amy. I appreciate your enthusiasm, though.
Just kidding.
You are now muted.
Odin, stop. Stop. No. Stop. Odin. Stop. Stop.
Now, the potential answer. I'm looking. Okay. Well, what is an MRI machine? What does MRI stand for? Or what's the first letter stand for, at least? Anybody?
You are now unmuted.
Magnet.
Imaging.
So what don't you want to put in a big old magnet machine?
Pacemaker.
Metal. So what is something that a lot of people have implanted that would prevent us from letting them go into that big old magnet machine?
Pacemaker.
A pacemaker. Good. So that's one of the major limitations of ordering an MRI for a patient. So some patients are perfectly fine to go to MRI. That is a possible source of imaging. But if your patient has had any type of metal implantations, they should not be sent for an MRI. What's going to happen if you put them in an MRI machine? It's going to rip the metal from their body. That's going to be a big old mess. Yeah. So that would be a major limitation of using an MRI machine. All right, Amanda, your turn. What is typically elevated in patients with restricted lung disease?
Are you so elevated with?
Or
Are
what's
you-
the problem for those patients?
Okay, so they, my first instinct is going to say increased compliance, but I don't
Do they
know.
have increased compliance? Do they have stretchy lungs? Do their
No.
lungs usually accept large
They have
volumes?
decreased compliance.
They have decreased compliance, so it takes what? Or their problem is what? Or you have an elevation in what?
Elevation in there.
Is it going to be easy to inflate their lungs?
No.
So what is going to, what's their problem? What are you going to see an elevation in relation to inflating their lungs? It's going to take more what to inflate their lungs?
It's good. Take
Let's call somebody. Somebody?
Pressure.
Yes, requires more pressure to inflate their lungs, requires more an elevated amount of pressure needed to expand their lungs. It's like my genes. Gonna take some pressure to expand those genes to get me in them. Okay, they are not very compliant. Your leggings, on the other hand, are very compliant. Okay, sure. That's why we love them. Enrico, what is the most common measurement of pulmonary mechanics?
Transpulmonary pressure?
You ever measured that?
No.
Me neither, girl. So what else do you think it might be? What volume or capacity? Because that's what we usually measure, right, during PFTs.
I'm still looking. Hold on.
Think about something that you measured when we had our PFT class.
FVC maneuver?
Yeah. It's your FBC. Why do you think that that's the most commonly measured, or the most commonly measured capacity or volume? What do you get from it? Friends, what do you get from if your patient does the FVC maneuver, what information do you get?
The FEV1,
You get what else?
FEF 200 to 200,
What else?
FEF 25 to 75,
What else?
and FEV1 FVC.
Yeah, so you get all those things from one maneuver. So why not just have them do that and you get all this other information? It's the best indicator of what type of disease. The VC, FVC, FVC.
Restrictive?
Restrictive. So would it be high or low if your patient has restrictive disease?
Low.
It would be low if your patient has restrictive disease, exactly. So what about all those values that Taylor said, the FEV1, the FEV1 FVC ratio, the FBS? What kind of studies are those?
Flow studies.
Those are flow studies. So if those are decreased, what does it tell you about the patient?
Obstructive.
That they have obstructive disease. How do you get those parameters? What did your patient have to do for you to get those parameters?
PFTs.
The flow loop?
They had to do the FVC maneuver, right? Because that's how you get a flow volume loop. So again, all this information that you get from one test, one maneuver. So that's why it's the most commonly performed maneuver or the most commonly obtained measurement, your FVC. And remember, you get your flow volume loop from your FVC, you get all those other parameters that you can then interpret. Okay?
Okay.
I like PFTs. That might be the only one. AJ, what's the primary problem in obstructive lung disease?
Primary problem.
Mm-hmm.
Their compliance increases, pressure
Okay.
decreases. It's an increased airway resistance.
Yes. So it's not really a huge problem that they have increased compliance. That's fine. But it's the fact that they have the increased airway resistance, which causes what to happen?
Causes pressure in their lungs, or causes them to not have adequate enough. They can't take in enough air into their lungs.
They can get there and fine.
For obstructive? Oh, they can't get it out.
Right. They can't get it out. So that's why, so that leads to what? Why do they have that barrel chest?
It leads to
They can't get the air out. They have air
entrapment.
trapping, which is why they have the barrel chest, which is why they have the increased AP diameter. They can get the air in just fine. They can't get the air out. So their lungs are very compliant, but they're not very
They're not very full, or they're not very elastic.
Exactly. They're not very elastic. Remember, the elasticity is their ability to contract, to go back to their normal state. They can expand, they just can't go back to their normal state. So that's like if you stretch out your legs. Then they're just sagging and backing, right? Because they don't go back to the normal shape. Okay. Flow. What volume or capacity will reflect the change in compliance?
What volume or capacity will reflect the change?
In compliance.
The change of volume divided by the change in pressure?
So if your compliance increases or decreases, what volume or capacity will also change?
I'm sorry, what did you just say?
So if your patient's compliance increases or decreases, what volume or capacity will also decrease or increase and reflect that initial change in compliance?
Your FEV is your, I don't know what you're asking.
Is that a volume or
Oh, the capacity.
capacity? So think about your volumes and capacities chart. What parameter or what value there will change if your compliance, okay, let's say increase. If your compliance increases, what volume or capacity will also increase?
Oh my gosh, your vital capacity.
So, okay, so tell me what vital capacity is.
That's your maximum inhale, your maximum exhalation followed by maximum inspiration.
Other way around. Because you can only measure what you blow out. So max inhale followed by max exhale. Right?
Your vital capacity?
Mm-hmm.
Oh, I'm reading right here. It says max exhale followed by max inhale.
Okay, so okay, if you said it that way the first time, great. But so it's the same thing, you're still only measuring what you exhale.
Oh, okay. And
Right.
I'm measuring everything that I inhaled.
Huh?
I'm sorry, I'm a little confused here. I guess
So can you measure what the patient inhales? You got a respirometer sitting in their lungs for when they inhale it?
no, because you can only measure what they exhale because they inhaled. Okay.
Yeah.
Okay.
So that's not necessarily going to change because if their compliance increases, yeah, they can take in a big breath, but are they going to be able to blow all that out effectively, very well?
No.
Right, because they have air trapping, their air gets stuck in their lungs. So what volume or capacity will increase if they have increased compliance? What is the volume or capacity that tells you what's left in their lungs after exhalation?
The functional residual capacity?
There you go. Because that's what's left in your lungs after what?
That's the gas in your lungs after a quiet exhalation.
Right. So if these patients have increased compliance, if they're obstructed, if they can't get the air out, the amount of air that's left in their lungs after a normal quiet exhalation is going to be increased. Right? So as their compliance increases, that FRC is also going to increase, showing that they still have a bunch of air left in their lungs. That makes sense?
Yeah.
Okay. So if you wanted to break it down, because your FRC is 2 volumes added together, right?
Yes.
So that's correct that your FRC is going to be increased. If you wanted to break it down to volumes though, what 2 volumes would be increased, causing that increase in FRC?
Your ERV and your RV.
Good. Yep, exactly. All right, any questions about that for the floor? Speak now, forever hold your peace. So Mallory, what are the definitions of your ERV and RV?
You said for ERV?
And RV.
Like, what do they stand for?
No, what are the definitions of them? You can tell me what they stand for too, though. That would be great.
Mommy, more.
I don't know. This unit I really struggle with.
More.
Okay.
I hear more. More. More.
Definitions. Hold on, let me see. Can I phone a friend?
Sure. But if you struggle with the unit, study extra hard.
I need to.
France?
Okay, it's ERV is your maximum exhalation following a quiet exhalation, and your RV.
Hold on for a second. Yes, thank you. So let's think about that for a minute. What is that really? Right? Because these words don't necessarily compute sometimes with our brains for us to really fully realize what's happening here. So can anybody break that down a little bit further?
Okay, so when you take a normal breath, you have to exhale. So you're letting air out, and then whatever you let out after that.
Right. So you exhaled your normal breath, which would be what?
A tidal volume.
Your tidal volume. Then, so after you so everybody take a normal breath in, let it out. Now take a big breath out. What you just exhaled was your ERB. Okay, so that's the maximum amount of air that you can exhale after a normal quiet exhalation. Okay, so what's your RB?
The gas remaining in the lung after that max exhale.
Exactly. So even after you guys let out a normal breath, then exhaled as much as you could, you still had air left in your lungs, and that was your RB. Okay, so for what type of people, Mallory, would you see those values are increased? Or people with what conditions, I should say.
Obstructive.
Obstructive or restrictive?
Obstructive.
That is fancy.
Obstructive.
Why?
Because, okay, hold on. Because they can't get air out, right?
Right. Yeah, because they can't get the air out. So the amount of air that's left in their lungs after quiet exhalation is going to be bigger than normal. The amount of air left in their lungs, even after a max exhalation on top of that, is going to be higher than normal. Yep. So those people are going to have increased ERB, increased RB, and like we said before, an increased FRC, because your FRC is made up of your ERB and your RB.
Okay.
Woo! PFT fun. All right, Nicole, what is the normal value for your IRB, VT, ERB, RB? So that last column of 4. What is the normal value for each of those?
You say my ERV?
So your IRB, your VT, your ERB, your RB. So if you're looking at your volumes in the capacity box, if you're picturing it in your mind, that column with 4 different volumes in it. What are the normal values for each of those volumes?
My IRB is 3.1 liters,
Mm-hmm.
and then my VT is 0.5 liters,
Mm-hmm.
and then the ERB is 1.2 liters, as well as same as the R.
Okay. How many milliliters?
Huh?
How many milliliters for each of those?
1,200.
Okay. How much for your tidal volume?
6.0 liters or 6,000 milliliters. Milliliters.
For your tidal volume?
Oh, for tidal, I'm thinking total. Sorry. The tidal volume is 500.
mLs, yeah.
Yes.
And then so your IRB would be.
The IRB is the 3.1.
So wait a minute, your IRB. Are
My
you?
IRB
Yeah.
is 3,100.
Are you looking at IRB or something else?
You asked for the IRB,
Mm-hmm.
which is 3.1 liters.
Okay. And how many mLs?
3,100.
Okay. What's your IC?
IV
IC.
Oh, IC. The IC is 3.6 liters.
Because it's your IRP and your BT added together.
Yes.
Yep, okay, good. All right, Taylor, how do you figure out a patient's normal vital capacity? You don't necessarily have to tell me the steps, but what should it be?
Like the normal value for
You would have to know some information about the patient to give me their normal value. So tell me the range. So it should be blank to blank, something per something of their something.
I know this and I can't fit. Is that the 65 to 75?
Mm-hmm. So 65 to 75.
Oh my gosh. Is it kilograms? No. What is it? Oh my gosh. I had it written down somewhere. Wait. Is that with the ideal body weight?
Mm-hmm. Mm-hmm.
There's ideal body weight, and you multiply that by 1, and that's your vital capacity?
Mm-hmm.
Oh my
So
gosh.
65 to 75, blank per blank. Friends?
65 to 75 per kilogram of ideal body weight for the height.
What per kilogram?
Milliliter.
Milliliter per kilogram of ideal body weight. So what that's saying is that for every kilogram they weigh, their vital capacity should be another 65 to 75 milliliters. So if your patient weighed, if their ideal body weight was 100 kilograms, what would their ideal vital capacity be? The range.
I'm sorry, what'd you say?
If your patient weighed 100 kilograms, what should the range be for their vital capacity?
65 to 75, 6,500 to 7,500?
Exactly, 6,500 to 7,500. So if your patient weighed 1 kilogram, then their vital capacity would be between 6,500 to 7,500. So for every additional 1 kilogram, you're going to add another 65 to 7,500. So basically, you're going to take their ideal body weight in kilograms, multiply by 65, multiply by 75. That will give you their range for what their vital capacity should be. Any questions about that? Okay, Alfie, how do you figure out your patient's ideal body weight? She's disappointed in that question. Sorry.
For females, 105 plus 5 times 60. 105 plus 5. 105 plus 105 plus 5. Oh my god, I forgot. Times 50. I forgot. Sorry, Miss Gardner.
I said, no, that's not correct. I was saying, phone your friends.
It's 105 plus 5 times height minus 60.
Right. So, and remember your height minus 60 is in parentheses. So you're going to do that division, that subtraction first. Then that number is going to be multiplied by 5. Then you're going to add 105. Okay. And that's going to give you your ideal body weight in what? In what unit of measurement?
Pounds.
In pounds. So if you needed that weight in kilograms, what would you do?
Multiply by 2.2.
Divide by 2.2.
I divide by 2.2.
Divided by 2. Okay. So Amanda, what was the formula for alveolar minute ventilation?
Alveolar minute ventilation, so you can take their tidal volume. Wait, hold on. Alveolar. Okay, so they'll take. I gotta write it down. Then I gotta explain it to you. Hold on. Sorry. So it is. Okay, so it is the tidal volume minus their dead space times their respiratory rate.
Okay. How can you estimate the patient's tidal volume?
Their ideal body weight times 3.
Mm-hmm. And how can you estimate the patient's dead space?
Ideal body weight times 1.
Mm-hmm. Good. Awesome. And what's the normal range for respiratory rate?
Between 1600
Respiratory rate.
or 8, or sorry, 12 to 18.
Girl, good. Yeah, 12 to 18 depends on what book you look at. Yeah, good.
I instantly heard heart rate. I don't know why, but I instantly heard heart rate.
Yeah, I knew this where you were going with that. Andrika, describe the difference between shunt and dead space.
Okay, dead space is where alveoli are ventilated but not perfused.
Okay.
And then shunting is alveoli are perfused but not ventilated.
Mm-hmm.
Okay.
So can you say that in a way that maybe makes it's kind of more like a more lay person description, or give an example of each of them? Sorry, your sound made me laugh. That actually was a pretty good breakdown. So yeah, just give me an example of
I was
it.
about to say that was the way that I remember it.
Yeah, that was actually really good.
An example. I don't know.
So what would cause your alveoli not to be ventilated?
You are now muted.
Odin. What the?
It's ventilated meaning that there's gas getting down there to the alveoli, right?
Right.
So what would prevent gas from getting down to the alveoli to participate in gas exchange?
Shunting.
Well, that is shunting, but what would cause shunting?
You are now unmuted.
Not enough blood flow.
So tell me the definition of shunting one more time.
Where alveoli are perfused but not ventilated.
Right. So shunting would have nothing to do with blood flow, heart's working fine, right? There's something that's preventing the air from getting to the alveoli to participate in gas exchange. They're not ventilated. They're not getting blood flow. So what would prevent it? Oh, I'm sorry, they're not getting airflow to them.
You are now muted.
Blood flow is fine. That's what you said, right?
Right.
So what would prevent the alveoli from getting the gas that they need to be able to participate in gas exchange? What lung problem could exist that would prevent those alveoli from being ventilated?
Like this is.
France.
Pneumonia or atelectasis.
Pneumonia, atelectasis, pulmonary edema. Anything that will either cause the alveoli to collapse, because if it's collapsed, is it open for business? Ventilated? Nope. Or if there's stuff stuck in it, that will prevent that gas from flowing down to the alveoli to participate in gas exchange. So if it's full of mucus, if it's full of fluid,
Yeah.
right? Pulmonary hemorrhage, if it's full of blood, any of those things are going to prevent that gas from going through the alveoli. Okay. So what would cause a dead space? And how would you know that the patient is shunting?
Just for anybody.
Mm-hmm.
When you're giving them oxygen, but you're not seeing it in like an ABG or anything of that nature.
You're
You're
not seeing it at
it.
Pulse ox.
And what is that called?
Their saturations.
What is that phenomenon called? The fact that you're giving them oxygen, but you're not seeing any improvement.
Something refractory.
You are now
You gave them
unmuted.
some oxygen, they're still hypoxemic.
That refractory hypoxemia?
Refractory hypoxemia. Good. Okay, so Enrico, what would be a cause of dead space or a dead space?
Pulmonary embolism.
Yeah, an embolism, because that would stop blood flow. The patient, at least for a while, is still breathing, or like we said, that patient with the pulmonary embolism, they coded, we're bagging them. Those alveoli are still being ventilated for as long as we're bagging, right? But there's no blood flow going past them. Okay, so good. I'm glad that you broke down the definition to a way that it's easier to understand, but you guys take it a step farther and make sure that you got it and can apply it.
Okay.
Okay, because the definition is, if you tell me, that's great, but gotta be applicable.
Okay.
All right. So AJ, where do the conducting airways stop?
The conducting airways at the high level?
No.
Would it be at the major bronchial stem?
And the what now?
Is it the major bronchial stem? Yeah.
Mm-hmm. So back to your generations.
Trying to think of it. Is it at the tracheobronchial tree?
Okay, that's where air flows, period. So where do the conducting airways stop within that tracheobronchial tree?
When you mean conduction, you mean like when the person breathes in the air?
Like the definition of conducting airways. So the airways that don't participate in gas exchange.
Okay. So that would be all of them except for generation 18.
So the conducting airways are generation 0 through 16.
0 through 16. Terminal bronchioles is when they stop.
Right. That's where air gas exchange starts to occur, right?
Yes.
Yeah. So everything that is in that tracheobronchial tree up to that point is useless. What do we call that volume of gas?
In space.
Space.
Mm-hmm. Thank you, Nicole.
Oh, sorry. I thought it was open to the floor. I'm sorry.
Thanks, Nicole.
No, we was working on it. Yeah, so with dead space ventilation, that's what does not participate in gas exchange, never reaches the alveoli, it's useless to us. Okay? So, AJ, where are patients most likely, since we're on the Pulm A and P unit, where are patients most likely to aspirate? Right or left?
It would be the right.
Yep, why?
Because it's straighter angle.
Mm-hmm. Less of an angle, larger, shorter airway. What is that point where the trachea splits?
Carina.
Yep, carina. Good. What's another word to call it? Another definition for it? It's the point of
Bifurcation.
bifurcation. Yep, very good. All right, good. Flo. When you palpate a pulse, what are you feeling?
Vibrations.
Of chakras?
Excuse me?
Of chakras?
What did you say?
I was being sarcastic. I said of chakras. So when you feel a pulse, when you palpate somebody's pulse, their carotid or their radial pulse, you're feeling vibrations?
Why every time you ask everybody everything, I can answer everybody else's question? My brain is not working every single time you ask me a question. Oh my goodness. What am I doing wrong?
Your block is in the wrong space. That's what it is. Okay, I'm sorry, what'd you say?
Okay, the question was, what am I feeling for when I palpate somebody's pulse?
What's actually happening when you palpate somebody's pulse? What are you actually feeling? What's going on in their body that's producing what you feel?
There are the blood flow through the arteries.
Mm-mm.
No.
Every time blood flows through the arteries, it causes that thump, thump, thump that you feel?
That's your blood leaving your heart, going through the rest of your body.
No. Well, okay, leaving your heart as in, tell me more.
Okay, let me see. My brain gotta think. Okay.
Okay.
I'm feeling what I'm feeling for. It's the heartbeat.
Okay, so what part of the heart?
My right, left side.
Which chamber?
It would be the left atrium. No, because the one that pushes is the ventricle.
Mm-hmm. So every time you feel that thump, thump, thump of a pulse, you're feeling what?
Your cardiac output.
You went over there.
Okay, the contraction of your ventricle.
Yeah, so you're feeling left ventricular contraction when you feel that thump, thump, thump every time you feel a pulse. Yep. So what pressure is produced when that ventricle contracts?
Systolic.
Which is normally
120.
Very good. All right, Mallory, what does the P wave represent? What does the QRS complex represent? What does the T wave represent?
P wave represents repolarization? No.
What is repolarization?
Or not repolarization, depolarization? Is it?
And depolarization is what now?
Is it when the ventricles relax? Or no? Hold on.
So depolarization is relaxation? Is that what you said?
I think so, right? No. By the way you're looking at me, it's wrong.
What'd you say?
By the way you're looking at me, it's wrong.
I need one of those. I need a fan.
Okay, so then that's when it contracts.
Mm-hmm.
Okay.
So the wave is contraction of what?
The ventricles.
Try the other chambers.
Say that again?
Try the other chambers.
What?
Try the other chambers.
The arteries? No.
The chambers of the heart.
Okay.
So in the heart, you have ventricles and
I know this and I don't know why it's not coming out of my mouth.
that would be a good place for it to leave your body.
Like I have heart problems and
And you're gonna be an RT. So
feel that too,
that's
but
bad.
oh my god. Phone a friend.
Atrium.
Your atrium.
Atrial depolarization.
Oh my god.
So now that we got the T-wave out of the way, atrial depolarization. What's the QRS complex represent? Now,
Hello?
Okay, QRS. QRS is doesn't it like it starts right before the contraction? Am I wrong?
and what do you mean it starts right first? What is it representing? What's happening to make that QRS complex appear on an EKG? What's the heart doing?
Contracting?
What part of it? Because you know that the heart doesn't just all contract at once and release at once.
Is that the ventricles?
Yes, that's the ventricles.
That's the ventricles.
That's the ventricles. So the ventricles are doing what now?
Contracting.
Contracting. So the QRS complex represents ventricular contraction, and then the T wave represents
The ventricular depolarization.
AKA
Relaxing.
repolarization.
What is-
Relaxing.
Okay.
Yeah.
Repolarization. Where am I getting depolarization from?
Because that's contraction.
Okay. Okay.
Okay. Nicole, what is a PVC?
Premature.
A PVC is a premature ventricular contraction.
You are now on.
And what can cause that?
The heart, the ventricles not contracting, like pushing enough blood flow. So you get PVCs and
Blood clot.
yeah. It's not. It's the ventricles not pushing enough blood. So it's like the ventricles having an, for example, an embolism or blood clot or something. Then we get PVC. No. Let me see.
So describe them. What does it look like?
There are big, bizarre, big like QRSs. This it happens like it's before. It's like an early contraction or something of the ventricles.
Or something. Weird. Yeah, so it's wide, it's bizarre.
Yeah, wide and bizarre.
Is it still a ventricular contraction? Is the ventricle still allowing blood to leave the heart?
I think.
I'd say yes, but it's more not enough. It's not being
It's still it's ventricular contraction.
Yeah.
Yeah. It's legit. Yeah. Let's leave it apart.
Yeah.
But why is it a problem?
Let me see. I mean, it's a problem. You say, why is it a problem?
Mm-hmm.
It's a problem due to it can cause blood clot, or there's a blood clot in the blood view.
Why would it be a problem?
Because the blood isn't being leaving the ventricles.
I thought we just said less ventricular contraction, so blood is leaving the blood.
With a decreased blood flow.
Who said that? So is it happening? It's a premature ventricular contraction, which means that it's happening out of clearance. What should happen before the ventricles contract?
Before the ventricles contract, then it's relaxed, and then.
So if you're looking at the rhythm strip, what would you see before a QRS contract? What should, so with the PVC, do you see a P wave first before it in front of it?
No.
So it's premature.
Right.
The atriums haven't contracted and relaxed and handed the baton to the ventricles.
Mm-hmm.
So it's happening at a turn. It's like if you're popping in somebody's butt in. Does that make sense?
Yeah.
So that's why it's a problem. If it happens over and over and over and over again, that's when it becomes a bigger problem. Because if it happens over, but it's still, the patient has cardiac output. They should still have a palpable pulse if you see PVCs here and there, right?
Right.
For those of you who have watched monitors and stuff like that, do they call a code if the patient starts to have PVCs?
No.
Because they still have palpable output.
Right.
Yeah. So it's not until it happens over and over and over and over and over without normal people that we usually get nervous. And what is that for? If you have PVC, the PVC after PVC, just a string of PVCs.
That's VTAC.
That's VTAC. So that's when it's a bigger problem. But it's a problem because the patient's cardiac output is diminished.
Mm-hmm.
It's a problem because it's not going in the right order, which can lead to a problem like VTAC. And a patient can have, because I think it's somehow on your end where the background is coming from. But so when a patient can, even in VTAC, they can sometimes have a pulse, right? When does it become pulseless? This is just open to the floor.
When the pulse is over 300?
Exactly. But up until that point, if you palpated a pulse, would you feel one? Because it's not pulseless VTAC.
Up until that point, you
Up
said.
until that point, right. So if you feel a pulse, does that patient still have cardiac output?
Mm-hmm.
Are they still alive?
Yes.
So it's not okay, but they're not dead. It hasn't affected their cardiac output. Okay. Well, what rhythm does affect your cardiac output to the point where there is no cardiac output?
Oh, would that be the
VFib.
Yeah.
So are the ventricles contracting?
No.
What is it?
Nick.
I can't hear.
They're quivering.
Oh, I was asking what the ventricles are doing. Yep, they're quivering. So it's the equivalent of what? Cardiac.
Standstill?
Standstill. They got zero cardiac output. Your patient is, let's fill that blank in too. Dead. Yes. Your patient is dead. So what should you do?
All code,
And
start compressions.
start compression. If your patient was in VTAC with a pulse rate of 250, would you need to start compression?
No, because they have a pulse.
If they had a pulse, no. Right? So if you palpate a pulse and you feel a pulse, you do not need to do compressions. If you palpate a pulse and you do not feel a pulse, you do. So VFib would be a time where you probably wouldn't feel a pulse and you would need to do compressions. Is it shockable?
No. Yes, yes.
Yes. What is not shockable?
It's the A1.
Yeah, which is, what is it, Taylor?
Basically,
Asystole, which is
no rhythm.
nothing. You got a
Okay.
flat line, exactly. And what do you do then since you can't shock them?
CPR, that's all you can do.
That's all you can do. Give them drugs, give them epi, and do compressions. That's it. What's going to be your compression rate to ventilate, compression to ventilation rate?
30 to 2.
30 to 2. Good. All right, Alfie, what is it called and what's going on when you have a patient who has a normal rhythm on the screen, but they don't have a palpable pulse?
So it is PEA,
Mm-hmm. And what does that stand for?
pulseless, pulseless electrical activity.
Right, pulseless electrical activity, aka
E something. Electrical mechanical dissonance.
And so what is happening if your patient has a normal rhythm on their screen, but they don't have a palpable pulse?
You mean what are the causes?
Well, what's what causes that?
Cardiac trauma.
Could be. Mm-hmm.
Tension pneumothorax.
Mm-hmm.
How?
So what's happening between what's happening in the heart and the electrical signal? Are they on the same page?
No.
No. So like you said, it's that E and D, the D means dissonance. So there's a disassociation between what the heart is doing and the electrical signals that it's sending out, which is why something normal would show up on your monitor, but your patient will be pressing. Okay, so what should you do for that patient?
Check on the patient and check on the pulse.
Okay. And what would you find when you assess them for a pulse? If it was PEA?
Cold.
Yeah, they wouldn't have a pulse because it would be PEA. So you would call a code, you would start compressions. The problem with PEA is that you don't necessarily know that they're in PEA until you touch them, until you go into the room to assess them. The monitor is going to show something normal, something that should produce a pulse. So it's not going to tell you, the monitor tech, oh my gosh, let me call a code, or let me call a telemetry alert, right? Because it's fine. So that's why it's a problem. Okay, any questions? All right, so notice that aside from our X-ray questions, everything else was from 210.
Okay.
Did y'all catch on to that?
Yes, ma'am.
Yeah.
Good. So everything that I asked, you should know by heart. Okay? So I'm gonna start here. I have a feeling that your brains are starting to get a little tired on me. My brain's getting tired. So we're gonna stop for today. I'm gonna let you guys study a lot for the remainder of the day. Okay? So remember, 210 stuff is fair game. And so these are the types of questions that you'll be asked in your oral boards. This type of things we asked today, again, this is old stuff. This is from last term that you should know, off the top of your head. So it's going to be that plus anything from 210 that is fair. So I want you guys to not only go and maybe make this a 210 day. Maybe make today the day that you really focus on going back to your 210 notebook and studying all those PowerPoints, studying all those units. Okay? So that's what I want you guys to do for the remainder of the day. Okay? Any questions? Anything that we need to go over? Anybody want to do a private conference to go over any units or topics or subjects?
How many questions will the exam be?
Probably 75. Between 75 and 90. I'm not sure yet. Okay, so we're entering the second half of the term though, so I don't want you to just, I want you to focus on towards the end of the term too, because then of course you'll have, and this is your first time having a midterm, so then you'll also have a final exam. But again, since we haven't been in clinicals, I know that it's harder to start developing those verbal skills, but I don't want you guys to neglect that stuff either, or feel like that just because we're not going over it anymore, just because we're past 210, that it's not going to come back up, because it will. Okay, so like I said, use today wisely. Take the time to really, really start to study, not just this term stuff, because this term stuff should really be pretty fresh in your brain, but go back to that stuff that you may have forgotten. It's easy to forget when you're not using it. Okay, so utilize today wisely. Not a nap, not whatever else. Studying. Okay, so I have not heard back from Ms. Buckley. I know that some of you need to meet with her tomorrow, so I'm going to reach out to her again and see if I can confirm a time, and I'll let you guys know. Tomorrow, you all have a study guide to do, a midterm study guide. So I'll let it be an independent work day, because I know that some of you will probably be going to the campus. So it'll be an independent work day. Y'all can work on that and just let me know if you need to have a one-on-one session and we need to go over stuff. Okay? Wednesday, of course, is our lab day. So it'll be the same before with our extended lab days, 3 hours, about 3 hours for each group. I'll send you guys videos for your MDI, DPI, SMI administration. But remember to study your drugs, come prepared, come with your PowerPoint from RT210 pharmacology, come with books, come with resources. Because if you don't know the answer, you need to be able to find it. Okay, but study, watch the videos, go back and look at that material so you don't come in clueless. All right, any questions? comments, concerns? Okay, but I'm available 8 to 2 today, tomorrow. I'll see you guys Wednesday, and then we'll have our midterm on Thursday. So please, please, please let me know if you need any extra help. Okay, trying to give you time to study on your own, but I'm available if you need extra help. I don't want you to feel like I'm neglecting you or I'm just giving you free range. It's time for you to study without having to spend 8 hours of your outside time doing this, especially since we don't have a new topic. So take advantage of it.
Will we get another packet for the second half of the term?
Yes. Well, you have you should have all the information in your packet. You mean a schedule, like a schedule?
Yeah.
Yeah,
You
yeah.
you only gave us like the first 5 weeks because we didn't know from there on.
Right. No, but in your packet, you should have all your information for the
Right.
term. Yeah, but I'm going to give you a schedule assignment. I was trying to wait to see if we would hear anything back, like I told y'all at the beginning of the term, but since we didn't, then I'll make sure y'all have this by the end of the week so you'll know what to do next week.
Okay.
Yep, I have it all made up. I was just trying to wait to the last minute to give it to you guys in case it changed.
So we haven't, nothing has changed as far as clinicals?
Not that I've heard of. In fact, Memorial sent out an email from nursing, but obviously we're in the same boat, saying that they were, I don't know if they had, people were reaching out to them trying to schedule days or what, but they were like, this is a reiteration that we are not taking students. Apparently they have an influx in cases recently there. So I did hear that